Hello, I'm Dr. Ken Landau. Thanks for joining us. This is Well Now Doctor. We're going to be discussing treatment for atrial fibrillation. Obviously, it's a very common problem. It's estimated that there are about 5 million people here in the United States with atrial fibrillation. Considerable increase over the next several years anticipated. We expect that probably in the next 20, 30 years, the number is going to be about 15 million. We think that it might even be greater than the 5 million now because a lot of people with atrial fibrillation don't know it. They don't have any symptoms. They've never been diagnosed with atrial fibrillation, but those people are at risk for stroke. And we know that if we look at stroke occurring in people over age 65 or 75, you know that a considerable number, maybe as many as 25 to 50% of all strokes, occur in those people with atrial fibrillation. So the question is, why do people get atrial fibrillation? The answer is, well, because something's wrong with your heart, and something's wrong with your heart because you have a gene that may predispose you to the problem. Maybe you have some inopportune health choices. Maybe you consume too much salt, so you have high blood pressure. High blood pressure increases the risk. Maybe you've had a heart attack. Maybe you have congestive heart failure. Your heart doesn't function normally. Maybe you have some other kind of medical disease. Maybe you have high level of thyroid hormone, or maybe you drink too much alcohol, or maybe you have a chronic obstructive lung disease. Maybe you're just too fat. All of those reasons increase the likelihood of your developing atrial fibrillation. And then the question is, if you have atrial fibrillation, what should we do as far as therapy is concerned? How do you treat atrial fibrillation? And the answer is, that's a tough question. And it's a tough question because there's so many different kinds of symptoms that a person may develop or may not have any symptoms. And obviously, in those people without any symptoms, we have to go and do different things than we would do if you have symptoms. So the clinical situation, in large measure, determines how we're going to treat the problem. We know that it's more common in the Caucasian population than it is in the Asian American or in the African American population. We know that we have to consider anticoagulation. Anticoagulation is a major factor because we know that people who have atrial fibrillation with symptoms or without symptoms, with a diagnosis or without a diagnosis, people who have been treated and are thought to be back to normal or not, well, all of those people have an increased risk of stroke. Because remember, atrial fibrillation, even with treatment, is going to come and go and come and go. And we also know that the rate is very important. The rate at which the ventricles contract, obviously very important in determining whether we need to slow it down or whether we don't need to slow it down. Well, you have to realize that up to 50% of the people who have atrial fibrillation are going to revert back to normal on their own. And by the same token, those people are going to probably develop atrial fibrillation one or more times over the course of time. So if you have no spontaneous conversion back to normal, and if you have symptoms, and the symptoms are enough to bother you, then we have the option of deciding whether you need some kind of cardioversion, whether we should bring your heart back to normal, your heart rate back to normal. And we can do that several ways. The standard two ways are either with electrical cardioversion or with pharmacologic cardioversion. We can either shock you with a paddle, a defibrillator paddle, under controlled circumstances, of course, or we can do it with drugs. We can just give you some medicines, and hopefully with a longer period of time, but hopefully over the period of days to weeks, you're going to get back to control if you go and take the medical approach. Now, it's obviously also very important that we treat any predisposing conditions. So if you have low oxygen, we should give you oxygen. If you have high thyroid, we should give you some medicine that stops the thyroid from increasing in your system. If you drink, we should encourage you not to drink. We should encourage you to have otherwise normal healthful activities. If you have a desaturation of your oxygen because you have obstructive sleep apnea, again, oxygen would be an appropriate kind of therapy. So we treat the concomitant diseases, and then we're left with how do we begin the therapy? Well, we have several goals in mind as far as therapy is concerned. So we would like to prevent any thromboembolic disease. So we would like to prevent a stroke, or we'd like to prevent the blood clots from breaking off and going to your heart, causing a heart attack. We would like to prevent too rapid a rate, because we know that a rapid rate causes a cardiomyopathy, causes injury to the ventricles so they don't contract as well. We would like to treat any symptoms that you have as far as shortness of breath, easy fatigability. We would like to control both the heart rate and or the heart rhythm. Those are two separate things. The heart rate, the number of beats per minute of the ventricles, the bottom part of the heart, we can control that. Actually, we control that much more easily than we can control the heart rhythm, whether you're in atrial fibrillation or normal sinus rhythm. So those are two separate issues. Now, if we're talking about the rate control, we can do it either in a lenient fashion or in a strict fashion. In the old days, we used to be very strict about things, but nobody took the medicine anyway, so we became a little more lenient. Lenient means that we allow the normal resting heart rate to be anywhere less than about 110. And if we get the heart rate to less than 110, most people seem to tolerate that quite well. On the other hand, some people need a more strict approach because they have symptoms, and the symptoms don't go away with the normal resting heart rate of less than 110. And in these people, we like to keep the max heart rate when they're at rest of about 80, and then with moderate exercise, allow the heart rate to get up to somewhere around 100 or 110. It seems that both of those perform adequately, at least as far as preventing cardiac death, preventing stroke, preventing the congestive heart failure, or other kind of life-threatening disease. Well, it's important to realize that no matter which method of therapy we choose, it would appear that there's no survival advantage of any of them over a different one. But what we need to do is we need to consider preventing atrial fibrillation in the first part. Now, the genes can't be controlled, but we certainly can control your weight, we can control your blood pressure, we can control whether you're developing obesity or not. All of those things theoretically can be controlled, and if we do that, then we can reduce the likelihood of atrial fibrillation. And as a matter of fact, remember we said that it's an important consideration with the inflammation that goes on in the system, and it seems that we can decrease the inflammation, decrease some of the stimulus for atrial fibrillation by using certain medicines that we use to treat high blood pressure. Those angiotensin receptor blockers or the ACE inhibitors. If we do that, if we use those medicines, very commonly used, then we can reduce the likelihood of atrial fibrillation. Those are drugs like lisinopril, losartan, Biovan, those kind of medicines seem to reduce the likelihood of a person developing atrial fibrillation. And some people think even the statin drugs can do it. Maybe the statins are anti-inflammatory. They have effects other than simply reducing the cholesterol. Once upon a time, it was thought that if you took those marine fish oil, marine lipids, omega-3s, it was thought that you could reduce the likelihood of atrial fibrillation or reduce the consequences of atrial fibrillation. Now we think, nah, that isn't the case. It seems like the marine lipids or the PUFAs, the polyunsaturated fatty acids, or the EPA, doesn't seem to help much. We know that if you have atrial fibrillation for a very short period of time, say less than 24 hours, the likelihood of a spontaneous resolution, a remission, probably is higher than about 70%. So most people who have relatively short-term atrial fibrillation are going to get back to normal. On the other hand, if you have more than 24 hours, the likelihood of converting back to normal is progressively smaller. Now, we know that if you happen to have heart disease, if you happen to have some structural heart disease, if you happen to have left atrial enlargement, if you happen to be on certain kind of medicine, certainly if you happen to be older, the likelihood of reverting progressively decreases. And we know that if we use drug therapy can be effective in probably somewhere between 50% and 70% of people with atrial fibrillation. But we know that at least if we're trying to control the rhythm, the drugs that we use to control the rhythm might actually cause other heart rate abnormalities or heart rhythm abnormalities, and those heart rhythm abnormalities can go on and lead to major complications. So therapy can be a little bit tricky. Now we know that we have to pick one or the other, or sometimes we pick both, the rate control, the rhythm control, or do we go for cardioversion, either electrical cardioversion or drug-related cardioversion? Well, obviously we have to assess the disease, we have to assess the symptoms the person is having, assess the risk that the person has, assess the kind of medicines that the person had before, and then we have to make a decision as to how we're going to treat them. Now, we know that elderly people overwhelmingly can tolerate the condition without all that much trouble. And sometimes all we have to do in elderly people is control the rate, slow the ventricular rate down, get the ventricular rate down to normal, and then in those people, even though the top part of the heart is still fibrillating, the bottom part is beating relatively normally, and for most people, that's going to be adequate. Now, rate control or rhythm control, any special benefit, one versus the other? No, they both seem to work, and they both seem to work basically to the same extent. We do know, however, that the longer the person is in atrial fibrillation, the longer the person is going to stay in atrial fibrillation, the less likely the therapy is going to work. So in older people, it would lead us to begin therapy with rate control as the first option. Now, if a person has a lot of symptoms, if a person seems to be tolerating the atrial fibrillation relatively poorly, then we have some kind of cardioversion. And we could use either electrical cardioversion, where we use a paddle placed over the front of the chest, the back of the chest, and then put some electricity into the person, a shock, a defibrillation. And that seems to work relatively well, actually works very well. But then oftentimes it doesn't work for a very long period of time, because after all, you have those spontaneous generations of the electrical impulses that are occurring from the heart. And as a result, you tend to go back into atrial fibrillation, and that's very common. So if you're young, maybe we try some of the rhythm control. Hopefully you haven't been in abnormal rhythm for too long. And if you're older, chances are you've had the condition for a while, and then we'll use some of the rate control. It's a completely different kind of medicines. And as a matter of fact, if you happen to be older and if you happen to be undergoing heart surgery, then we know that, geez, you might be at higher risk for developing atrial fibrillation. So maybe we want to give you some prophylactic therapy. Maybe we want to give you some beta blockers to start with. And if we know you have a history of atrial fibrillation, then obviously the thought is that, well, maybe some kind of anticoagulation might be appropriate. When we talk about rate or rhythm control, people have long argued in favor of one versus the other, but the studies that we have, they show that it doesn't seem to make any difference. And as a matter of fact, if there's any edge, the edge would be to the rate control over the rhythm control. But statistically, there is no difference. We know that if we look at the rate control, people are less likely, a little bit less likely to get rehospitalized, to have cardiovascular death. Those people are a little bit less likely to have stroke, but it's only a little bit. It's not statistically significant. And we know that if a person has atrial fibrillation and now all of a sudden seems to be normal, it might not be our therapy. Therapy is one reason why the person gets back into normal rhythm control, but maybe they've had a toxic reaction to the drug, especially in the days when digitalis preparations were frequently used, digoxin, much less commonly used nowadays, thought actually to maybe not be a very appropriate drug, except some cases still has a role. Or maybe we have now the atrial flutter instead of the atrial fibrillation, or we have some other kind of an abnormality. But sometimes, even though we control the rate, maybe that's not enough. Because remember we said that the top part of the heart, the atria, when it contracts, adds some blood to the bottom part, the ventricle, so the ventricle can send it out to the brain and to the lungs and to the muscles. And sometimes you need that extra little kick, and if you need that extra little kick, then it might be appropriate to go for a rhythm control. Now we also know that people with atrial fibrillation have a tendency, as I said, to go into atrial fibrillation, out of atrial fibrillation, into atrial. So in some people, it's thought that, geez, you don't have to go to the doctor all the time every time you get atrial fibrillation. Maybe once you've had it for a while, once you know the kind of therapy, once you know you tolerate the therapy, maybe the doctor should just give you some pills, keep the pills in your pocket. And if you happen to develop symptomatic atrial fibrillation, just pop the pills. And oftentimes that works. And oftentimes that's very good. So we call it the pill in the pocket, where we give you some of the standard medicines like Rhythmol. And you keep it in your pocket. And then if you have atrial fibrillation, pop the thing, and maybe that's going to be relatively good. Now, some people have symptoms, and we don't know what the symptoms are from. The symptoms could be from atrial fibrillation, but they're not really the classic kind of symptoms. And for those patients, we obviously want to control the rate. If we are not successful at controlling the rate, they still have the symptoms, then we might want to go for aggressive rhythm control and see if the symptoms go away. If the symptoms don't go away, then, aha, that's not related to atrial fibrillation. So people can have a lot of symptoms, and we don't have explanations for all of the symptoms that people can get. So what kind of medicines do we use? Well, if a person presents and they have acute symptoms, then one of the simple ways, one of the very quick ways, is to just begin some beta blocker therapy. Some of the standard kind of medicines that we use, the beta blockers, the metoprolol, the propranolol, those kind of medicines, seem to control the rate pretty well because they stop some conduction at that atrioventricular junction, the junction between the top part and the bottom part. Or we could use some calcium blockers, very commonly used. Drugs used like verapamil or diltiazem, and up until recently we used a lot of digitalis type preparations. Acute termination of the event, if it's necessary because you're having some cardiovascular compromise, you're having too many symptoms, you need that extra 10%, well then sometimes it's appropriate to begin therapy with electroshock. But now electroshock therapy has some caveats associated with it. So if you've had atrial fibrillation, as we talked about, for more than 5 or 6 minutes, and certainly for more than 24 hours, it's highly likely that you're going to have some clot that's already formed inside the left atrium. And if we apply electricity to the chest, or if we use even the drugs, we might knock that clot off, and then the clot might actually gain entrance to the circulation and then cause major problems. So obviously we don't want to do that. So what we have to do is we have to, it's thought, if we're going to do electrocardioversion, get a person on a blood thinner, Coumadin, for a period of about 3 weeks. Because we know it takes somewhere around 3 weeks, 4 weeks, for the blood clot to actually go away, for it to be bound down to the wall and dissolved. So we know that that's a very important issue, both with electrical cardioversion and with the pharmacologic, taking the drug, and getting the heart rhythm back to normal. So we can't do it just immediately. We have to go and get the clots, any of the clots that might have formed, get those things to go away. Otherwise, we have a significant risk of a stroke or a TIA. And certainly in people who have conditions like rheumatic heart disease, or people who are older, people who are over age 65, those people are at greater risk. People who have high blood pressure, congestive heart failure, obviously those people are at greater risk. So we have to be careful, and we have to make sure that the blood is appropriately anticoagulated. If we use warfarin, if we use Coumadin, then we monitor it by something called an INR, blood test, INR, internationalized normalized ratio. So if it's between 2 and 3, then we're right at that sweet point. If it's too low, the clots can form. If it's too high, then a person has a greater risk of bleeding. So you obviously want appropriate anticoagulation. And we want the anticoagulation for a significant period of time. And then not only do we have to do it for about 3 or 4 weeks before therapy, we also have to continue with our anticoagulation therapy for at least 4 weeks, because during that period of 4 weeks, even if the heart rate is normal, even if we get back to normal sinus rhythm, then we find that the actual heart is stunned, S-T-U-N-N-E-D, stunned, and it's not performing normal contractions, and during that period of time, clots can still form. So we have to keep on appropriate anticoagulation both before and after we begin our therapy. Now that's obviously very important. And then, in addition to that, if we don't do it, if we say, well, geez, person just has recent atrial fibrillation, we just made the diagnosis, well, we can begin therapy, we can use the electroshock. It doesn't work like that, because remember, a person may well have had a significant period of time in atrial fibrillation before we even can make the diagnosis. So atrial fibrillation means if we're going to get it back to normal, we have to go and begin therapy with a blood thinner. And as a matter of fact, even in those people who are treated, here's an arguable point, but in those people who are treated and who are successfully kept in normal sinus rhythm, if the treatment seems to work, the question is, when can you stop the blood thinner? And some people would say never. Because remember, once you've had the atrial fibrillation has a high chance of coming back. Even if it doesn't cause any symptoms whatsoever, it can come back, and it just has to be back for a period of minutes before it increases your risk for suffering a stroke. So we need to assess the net positive, the net benefit, versus the potential for harm. So some people would say that if the atrial fibrillation has been around for less than 48 hours, well, we don't have to begin the therapy with the anticoagulation. There's never been a randomized control study of that, and that probably is inappropriate, and probably if you have atrial fibrillation, go with what I just said, 3 or 4 weeks before therapy, 3 or 4 weeks after therapy minimum for anticoagulation. So let's say you pick the electroshock. What does that entail? Well, the actual treatment is relatively simple. It's straightforward, basically the same no matter where you go. About 200 joules is applied to the chest. You have a paddle in front of the chest, over the heart, a paddle on the back, on the left-hand side, on the back. Person sedated. Get the shock. Shock seems to work. Sometime if you're very fat, if you have chronic obstructive lung disease, need a little bit more energy, might need up to 300, 350, 360 joules. If a person is thin, if a person is relatively small in frame, maybe considerably less, maybe just 120, 140 joules might be sufficient. We know that the likelihood of recurrence over a period of time, even if you have the electrocardioversion, is considerable. And we know that a significant number of people benefit. And the standard would be to begin a course of therapy and keep the person on a course of therapy over the period of the first month at least, or 6 weeks, because remember we said that there's some myocardial stunning. The heart muscle just isn't working properly after it's been fibrillating for a while. Now we know that if you've had the electrical cardioversion, overwhelmingly you'll get back to normal sinus rhythm. Maybe not for very long, maybe for only minutes or hours. And if you've had the atrial fibrillation for a long period of time, if you happen to be a senior citizen, and you've had the atrial fibrillation for some period of time, chances are it's not going to stay normalized after therapy. Chances are it's going to come and go. Now, if you don't want to go through the electrical cardioversion, you might opt for a pharmacologic cardioversion. Pharmacologic cardioversion doesn't work as well and takes a lot longer period of time, but you don't need the anesthetic. And some of the drugs that are used for atrial fibrillation and getting you back to normal sinus rhythm, they have a significant number of side effects, and they can cause the proarrhythmia. They can cause arrhythmias, cause other arrhythmias in addition to the atrial fibrillation. Might not work for the atrial fibrillation, but might now lead to another cardiac abnormality. Also, Remember, they can cause an increase in the incidence of blood clots ripping off from the inside of the heart and going to the brain, so you still need the anticoagulation. And as with the electrical cardioversion, if you've had the problem, atrial fibrillation, for some time, chances are less and less that it will work. So what do we know about therapy? Acutely, if you have the symptoms, if there is any reason, then you can go through a course of electrical or pharmacologic cardioversion. Both work best in people who have relatively short periods of time of atrial fibrillation. The longer the atrial fibrillation, because remember what we said before many times, atrial fibrillation begets atrial fibrillation. The more atrial fibrillation you have, the more often you're going to have the problem. The medicines that we use, if we're going to convert you back to normal, medicines like Tambicor, medicines like Rhythmol, sometimes Ticocin, the variety of other medicines. We also use medicines like amiodarone or Carvert. These are medicines that can be taken either by mouth or acutely. We can use an intravenous injection of some of the medicine, and the pill-in-the-pocket idea that we talked about very appropriately. Give people some medicines. Now we can control the rate, and we can use rate control, and rate control is generally used in people who are over age 65 and people who are otherwise healthy, people who don't have congestive heart failure, people who don't have kidney failure, people who have no previous kind of therapy. Sometimes people who have high blood pressure do well with these kinds of medicines because they're often used to treat high blood pressure, and we use it if a person has coronary artery disease oftentimes, or just because people like to take these medicines because they seem to be safer overall. These are the people who are not fit for either electrical or pharmacologic cardioversion. And we said that we can go for the lenient rate control at first, less than 110 resting, or if they still have symptoms, then we can go for a stricter control, less than 80 on a resting basis. But you have to realize that a lot of people are not going to take the medicines, and unfortunately, since they don't take the medicines, then we don't get as good a control as we would like. But some people, even though we bring the rate down to normal, remember, they need that extra 10% kick of the top part of the heart. And if they don't have that extra 10% kick, then they're going to feel tired, or it might set up their congestive heart failure. They might have other kind of symptoms. They might have angina, chest pain. So what we might have to do in those people, even after we control the rate, is those people might also have to then take medicine to control the rhythm. Well, success, if we use a beta blocker in bringing people to a normal rate, normal heart rate, bringing them down from 120 to 160 back down to, say, less than 110 anyway. If we use a beta blocker, metoprolol, one of those kind of drugs, propranolol, very commonly used. Well, the success is probably somewhere around 70%, significant success. If we use the calcium blockers, the verapamil, well, diltiazem, if we use those kind of medicines, the likelihood of success somewhere around 60%. So the medicines seem to work, but they're not the greatest things in the entire world. We have some of the medicines that can actually be used acutely intravenously. So it's very important to realize that one of the methods of therapy, the beta blockers, or sometimes the calcium blockers, seem to control the rate pretty doggone adequately, and by doing so, they increase the quality of life, they increase the exercise tolerance, the ability of people to exercise, and they decrease the likelihood of heart failure. So those are obviously good. But on the other hand, sometimes we need to control the rhythm. So how do we control the rhythm? Well, with the same kind of medicines, just different class of medicines. Now, these medicines seem to work better if the person is relatively younger, have a better heart, less structural abnormality. Sometimes if they're unresponsive to the beta blockers, or sometimes people just prefer to get back to what they consider normal rhythm. Well, the medicines that we have for this are medicines like Tambicor, medicine like Rhythmol, or Sotalol is another medicine that's very commonly used for the problem. And it all depends whether the person has structural heart disease or not. So a person who's had coronary artery disease or a heart attack, or a person who has a valve problem, a person who has other kind of problem with the structure of the heart, seems to need other kind of medicines than the ones I just mentioned, because those medicines seem to have a higher chance of causing serious arrhythmias. So for people who have structural heart disease, well, maybe we're more likely to begin therapy with a series of other medicines. Medicines like Drondarone, that's Multac, or medicine like Amiodarone. Those are very commonly used drugs. They tried to introduce some other drugs into the United States, but they found that some of the drugs actually were causing other kind of problems, and even though they're available in Europe, it's thought inappropriate for those medicines to be used here in the United States. The recurrence rate of atrial fibrillation, even on therapy, is in excess of 50%. Some people like to go and measure the drug levels, and they say, well, geez, let's measure the drug level, and we can tell if you have the right amount of drug in you, the right concentration, realizing that different people metabolize things differently. That doesn't seem to really help very much. We do need to monitor the electrocardiogram, because some of the drugs can cause abnormalities on the electrocardiogram, and that's what predisposes to arrhythmias, so that's obviously very important. There are different kinds of classes of drugs. We won't have to go into those, but suffice it to say that we have the rate control medicines, typically in an older population. In a younger population, we have the rhythm control medicines, hopefully get you back to normal. We can use electric shock, or we could use drugs to get you back into that normal rhythm. Well, all of the excitement in the room seems to be on the basis of what do we do with ablation. You hear so much talk about ablation. You hear atrial ablation, atrial ablation. It sounds like it's one kind of treatment. But actually, we know that atrial ablation is different things to different people. So when we come back, we're going to talk about atrial ablation, and we're going to specifically delve into the concept of anticoagulation. Anticoagulation. How appropriate is it? And what kind of anticoagulants? How do the new medicines that you hear advertised on the television all of the time, in the course of any given show, it seems like you're lucky if you can avoid an ad for Pradaxa or Xarelto or Eliquis. Are those appropriate kind of medicines? Are they really a major advance forward? Or are they just expensive and kind of untested? We'll discuss that on our return.